Maybe you like REBOA, maybe you hate REBOA, but no matter who you are, it is a pretty polarizing subject in trauma. And that's why we have Dr. Qasim live from the Resusc Reset Conference this last October in Philadelphia to break it all down. If there's anyone who knows about REBOA, it's Zaf, who's trained with it, who uses it, and I consider him to be the expert of all things REBOA. So let's check it out.
REBOA stands for resuscitative endovascular balloon occlusion of the aorta. And what that is that you're putting a catheter through the femoral artery up into the aorta and inflating that balloon above a point of critical hemorrhage. And that's really important. It acts like an internal tourniquet. And the reason that we need this is that we face this huge challenge still from potentially preventable death from hemorrhage. And we've gone a long way in the last 10 years or so with the use of tourniquets now. The military showed us that we can use that effectively in civilian population. There's these new hemostatic gauzes that you can put into wounds. But these are great if you have compressible sites of hemorrhage. But the real challenge becomes when you have non-compressible sites of hemorrhage, like the chest, the abdomen, the pelvis, and more importantly, these junctional areas, which are really tough to manage, like the groin, the axilla, and the neck. These conventional means like the tourniquets are really difficult to apply here. And really, up until the time that REBOA came around, when we had patients who were dying from this non-compressible torso hemorrhage, the really only option was to do this procedure, the resuscitative thoracotomy. Not to fix anything in the chest, really, but it's really just to put this clamp on the aorta in an attempt to stop bleeding below the diaphragm. Not great for our patients, right? The patient really just had to die before you could do this. It causes another body cavity to be open, so a real huge physiologic and anatomical hit there. And overall neurologic survival, not so good. And so a lot of research, especially when you saw the burden of death in the military world, was pushed to look at alternate means of hemorrhage control. And so a lot of animal studies came out looking at, say, hey, why don't we put a balloon up and see if that works? And actually, in the animal studies, it seemed to be doing pretty good. And so inevitably, there was a push to see if we could do this in humans. And so I was lucky to work at Shock Trauma in Baltimore when REBOA really started coming out. But it was a beast. You had to put in this huge sheath, a long guide wire. You needed two people. One was standing in another time zone because the wire was so long. And then you had to put this balloon catheter in. But when you compared it to what was being done already, which was the thoracotomy, it seemed to be a better thing. You could do this proactively before the patient died. There seemed to be less tissue injury. And at least the first cases seemed to be doing pretty good. A registry of data came out. So in the States, we have this aorta registry that kind of looks at comparing the outcomes from REBOA to thoracotomy. And certainly on the most recent kind of published data a few years ago now, they showed REBOA seemed to be doing a little better, but not so much if the patient was dead at the scene and then came in, or if they arrived and arrested in the emergency department. Then nothing really helped. But if you did this proactively before the patient arrested, REBOA certainly seemed to be better in terms of achieving survival benefit. But of course, you have to acknowledge that there's a bad side to REBOA, right? And this is one of several papers that have come out that looked at this. This was a retrospective review of the National Trauma Database using propensity score matching. But even though there were some statistical challenges with this paper, it really highlighted that there were some real complications and risks with doing this. And primarily that included vascular injury from sticking a big catheter into the femoral artery and end organ failure. When you're putting a catheter up into the aorta and occluding above the diaphragm, you're essentially taking away the blood flow to everything below that point. And the body doesn't seem to like that very much. Certainly with full occlusion, you can't go beyond about 30 to 45 minutes without the body saying, okay, I'm going to die now. But one of the biggest questions that we had as we evolved and saw what REBOA could do was that comparing it to thoracotomy probably wasn't the right thing to do, because thoracotomy has some clear indications and REBOA has some clear other indications. And why don't we just compare REBOA to standard care? And when this trial got announced, we were all excited in the trauma world. This is the first time that someone was going to conduct a randomized controlled trial comparing REBOA to what we do every day. So let's talk a little bit about this. This was done over in the UK at 16 level 1 trauma centers. They were planning to enroll about 120 patients and using fancy Bayesian methodology to look at 90-day outcomes. And so they presented the data over the summer, this past summer, and actually ended up stopping the trial after 90 patients were enrolled. You'll see the reason why, because it seemed like the REBOA arm was doing a whole lot worse when they got this. Now remember, this paper is not published yet, but the data is out there. A lot of people looked at this course data and said, that's it. Okay, all those frowny faces for REBOA are suddenly smiling, saying, hey, we told you, right? REBOA sucks and it kills patients. But of course, the devil is really in the details, right? So if you look deeper into the paper, you'll see that there's some real differences in those two groups. The biggest one, I think, overall was that it took the patient to get to the hospital before they could get randomized. And these patients typically spend about 90 minutes on scene. And so that's a long time for people to continue bleeding before they can get some form of temporary or definitive hemorrhage control. The REBOA patients were more likely to have a brain injury. They were more likely to be more severely hypotensive. And if you look at mortality graphs, when they get below 70 systolic, there's a huge rise in that inflection point of them dying as opposed to higher blood pressures. And then you'd think that all the REBOA arm patients did get REBOA, but only a few of them did. And overall, about only a third really ended up getting a definitive hemorrhage control procedure. So it's unclear whether they all needed REBOA in the first place. But if they did need a hemorrhage control procedure, then it took them ages to get to the operating room or the IR suite. And that's on top of the 90 minutes they'd already spent bleeding from the scene to arriving into the hospital. So all these things need to be taken into account when you look at this trial.
If you're enjoying this video, then I ask that you like and subscribe to the channel because it really helps the algorithm understand that people like you need to be seeing videos like this. So I really appreciate it. And if you're enjoying the video and you want to see more great resuscitation videos, then head over to resusx.com. The link is in the bio. You can check out all the lectures from the conference. And when you sign up and complete the conference, you can earn CME credits and CEUs. This is something that you don't want to miss. This is a conference by resuscitationists for resuscitationists, and I think you're really going to like it. So check out the link below, and let's get back to Zaf talking about REBOA.
So what can we take away right now from this? So certainly REBOA and thoracotomy seem to have some different indications. REBOA can address torso hemorrhage, but really the numbers are probably relatively low at any center. And it really does require skill, and it has some complications that you really need to be aware about. So knowing all this now, what's the future for REBOA? Is there one or not? I said this earlier, right? We face this significant challenge from potentially preventable death from hemorrhage, in particular torso hemorrhage, and that really hasn't gone away. Our numbers really haven't improved over decades of care. And there's a lot of kind of people looking at different options for addressing this. You can have these hemostatic agents, these sponges that expand and cause hemostasis, the abdominal aortic junctional tourniquet. But really, REBOA has really been the only kind of tool that can potentially address this issue. And remember, the bleeding is not just from trauma. We heard earlier about the OB bleeding patient, right? So a lot of women, unfortunately, suffer postpartum hemorrhage, and that's a significant contributor to maternal mortality. And so there have been a number of studies now that have looked at the use of REBOA, either proactively, if they know that they have like a placenta accreta or something, or as an emergency measure, if they're bleeding as they're delivering, to see if that would be helpful. And actually, as the data accumulates, you'll see that these women don't require as much blood transfusion, and they have a lower hysterectomy rate as compared to not using REBOA. So certainly an area where this can be utilized. Actually, the steps of REBOA can improve our resuscitation overall. And I would say that one key step, which is really the rate-limiting step of REBOA, is femoral arterial access. And so if you get a femoral arterial line, you'll see that it's a lot better than doing a peripheral arterial line. As you move away from the central circulation, there's certainly this amplification, which is false amplification of that reading. And so getting access early can actually improve your mortality. There's been a number of papers that have looked at this, where it improves survival, reducing your time to decision-making, including going to the operating room, achieving hemostasis. And actually, since you've already done one of the most challenging steps of REBOA, if that person ends up needing REBOA, it's really easy and quick to progress to that state. There's evolution in techniques that allow us to reduce these complications now. So remember, the biggest complication is that time of occlusion. And so as we evolve to different techniques like partial REBOA, you'll see that these devices are designed to allow a balance between occluding blood flow and permitting a little bit of blood flow to those vital organs as well. So you achieve a real balance there. And that's something that the previous devices couldn't really do. It was an on-off switch with the older devices. With the newer devices, you actually allow a more nuanced approach to getting that partial flow. And we're actually studying this. My hospital, Penn, is part of a multi-center trial that's looking at the outcomes of this. But the early data really does show that this partial REBOA is making a huge difference. So you can get longer occlusion times safely. You can now get CT scans on these patients because there's some blood flow that's going around the balloon, and you're achieving some hemodynamic stability. You can decide then that, okay, they don't actually need the operating room. We can go to the IR instead. And in fact, we're seeing that there's less ischemic injury from this, there's less blood product utilization, and the time to hemorrhage control is actually shorter, as is the length of stay. So certainly really important to look at this opportunity to improve the use of REBOA. This is just another comparison. So if you look at the old technique on the left compared to the new technique, even though they're similar occlusion times, there's much lower rates of acute kidney injury as well as mortality. So certainly an option to use down the line. But this is a lot to do, right? You get a super sick trauma patient. There's a ton of things that are trying to get your attention, right? So now you have to put in a REBOA and kind of figure out if you're getting it to the right pressure or not. You can get task saturated. And that's really where technology can really evolve the REBOA process. So there's people that are developing electronic control of the balloon where you can use like an app to just dial in what pressure you want, and it will then control the balloon as the physiology changes. So you can just set it and forget it kind of thing until you achieve all the other things that are out there. So this will come in the near future. So I'd say over the last 10 years, a lot has changed with REBOA. Our ability to identify the person who needs REBOA has improved. We looked at the technique that's really evolved. You've moved from that huge, nasty sheath and catheter that you were using to smaller devices. The Canadians have come out with this device that fits through a 4 French sheath. You can get this partial REBOA technique with a number of devices now. And in the future, we'll have some electronic control of this. And our ability to understand and manage and prevent those complications has really improved over the last 10 years. But really the crux of it is that over the last 10 years, these patients are still bleeding and there aren't many other options out there. So until we find something better, just stop hating on REBOA. Thank you very much.